later. We're excited to have an opportunity to have this open discussion about cracking the code on denials, and are grateful to have two industry leaders with us today, sharing their experience and successes in reducing denials. Let me first introduce, we have Donna Ramadan, Vice President with Revenue Cycle and Compliance at GLDP. She brings over 30 years of healthcare experience, a registered nurse with a background in ICU and trauma care. She transitioned into revenue cycle leadership and after earning her MBA from Northern Illinois University. She has led revenue cycle operations at major organizations, including Northwestern Medicine, Delnor Hospital, St. Anthony's Hospital, and the Cleveland Clinic. Donna is known for integrating clinical and financial expertise to drive effective operations and provider relationship. Thank you for being with us today.
Thanks,
We also have Kate Smith, Director of Revenue Cycle at OMS 360. Kate is an accomplished healthcare management leader with over 2 decades of experience in revenue cycle management and 7 years in consulting. She is a certified revenue cycle specialist with a bachelor's degree in health science from Central Michigan University. Kate specializes in revenue growth, AR reduction, workforce optimization, and operational efficiency. Kate's focus is to consistently deliver measurable financial improvements across diverse healthcare organizations. I'll do a quick intro of myself. I'm Anna Poliano, Product Operations Manager here at Centist. I actually joined the team about a year ago, but I do bring over 20 years of experience supporting dental organizations and improving efficiency and driving growth. I'm especially passionate about working directly with offices, streamlining operations and enhancing overall performance. With me from the Centis team is Cheryl Dean, also Product Operations Manager. She joined the team over 5 years ago and also has over 20 years of experience in both the dentistry as well as healthcare. We are both passionate about continuously enhancing our platform to better support our clients. Our goal is to drive effective work processes, streamline operations, and help practices achieve sustainable growth. Now, before we get started, we do have a quick surprise for everyone at the end. So we do ask that you all stick around for the end and see what it is.
Awesome. Thanks, Anna.
Yeah.
I'm going to quickly go over the agenda for us today. So first of all, we're going to talk about the state of the denials. We'll take a quick look at the 78% surge data from the 2026 Trends Report, which if you aren't familiar with this, it is a survey that we did across various size DSOs and practices across the industry. And that survey is available on our website if you're interested in reading it. Also, we're going to talk about the low denial roadmap. Donna and Kate will share some of their specific daily workflows with us. Next, we'll dive into proactive versus reactive RCM, how to move from fighting denials to preventing them using smart logic. And then we'll also do a tech deep dive. We'll take a look at how Remit AI automates the heavy lifting of denial management. And whatever time we have left, we will do some Q&A as well.
Awesome. Thank you. Now, before we get started, are we seeing our presentation?
I'm just sharing the screen right now.
Okay, perfect. I just wanted to make sure if it wasn't just me. I was like, I'm not
Yeah,
seeing it.
we just don't see it on our side, I think.
No, that's okay. I just wanted to make sure our callers were. Okay, thank
Yeah.
you. Okay, we want to take a look at the RCM trends. Claim denials are rising across the board. 78% of dental practices report increased denials over the last 12 months. The teams are struggling with complex policies. Medical necessity is becoming more frequent, as well as frequency issues. 7 out of 10 practices achieve a high first pass rate at submission. So, that's 70% of claims being processed by the payers. This confirms denials stem from payer policy changes. We recognize the challenge in the growing times and effort it requires from a team to achieve full claim payment, considering the issues with growing denials. So let's begin our roundtable discussion. What we're doing is we're using questions submitted by our attendees. Thank you, everyone, for providing those questions. These were very helpful. And we want to address what is relevant and what pain areas are you seeing in the industry today. So, Donna, what denial trends are you seeing with your current claims?
Well, I'm very proud to report we don't have a whole lot of denials, but the ones that we do see are related to SRPs and crowns and crown buildups. Those have, kind of historically been a bit of a challenge for us. And do you want me to talk about what we've done to solve it? Yeah.
I absolutely do, yeah.
The big thing that we noticed in digging into our data was it was largely about documentation. Our providers are very good at documenting like the technical part of what they did, like the procedure, but not the why, the medical necessity reason of why. So what we did to address that is build out templates in our PMS system that really guide the provider specifically on those crowns and buildups about documenting what does the tooth look like? Is there a fracture? Really establishing that medical necessity reason for the crown. So we have much more robust documentation from our providers, and we have seen a dramatic decrease in our crown and buildup denials. Similarly for SRPs, in working with our hygienists about what they need to document and making sure that there's appropriate radiology images attached and that there's appropriate probing depths. That is really key. And our hygienists weren't always documenting that to the right level. So once we partnered with our providers and explained like what's happening and what we're seeing and how you can help us prevent that, we saw a dramatic decrease in both of those categories.
Yeah, I would absolutely agree. I think that pre and post operative clinical documentation is key. Really understanding your insurance's processing policies to better understand what they're looking for in terms of that initial submission. Definitely helps on that.
I'm going to add something here. Just it kind of goes along with the SRP discussion is the full mouth debridement. I don't know, Donna, how your office has had if you've had issues with that, but that's one thing that I see a lot from our side that full mouth debridement you cannot bill a exam with the full mouth debridement. It will always get denied. So you really on all of those, really, it's critical to make sure you know what you can and can't do on specific procedure codes because that full mouth debridement seems to always come up because it's getting billed with additional codes and they're just not going to pay it when you do that.
Yeah, absolutely, Cheryl. Just to reiterate that point, when you cannot bill, the 4 quadrants, you will always get a request for additional documentation or data for that, and then most often results in a denial. So yeah, thank you for bringing that up.
And I think there's something across the board, kind of a common theme here. I mean, I'm in oral surgery, Donna's in general dentistry, but she said something very important, and that's partnering with your provider for that documentation. We do the same thing when we identify a trend coming through in our denials. We go back to our templates and kind of plug in those buzzwords there that they're really looking for. Our doctors are more of a kind of a click, 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 and it spits out their note. So when we see those, we do the same thing that Donna is doing is, go right back to our doctors and educate them, really, because they're not seeing what we see.
Yeah, no, absolutely. No, thank you for sharing. Now, Kate, being on this topic, what mistakes were made by your organization? What steps did you take to improve your workflow? I know you talked a little bit about that already. What do your denial management processes actually look like today?
Yes, so for us, we're partnered with Zentis and we really use our Remit AI and CaviAR tools to get that denials data. I think that denials data in the dental field is really something that's kind of falling to the wayside, right? A lot of our PMSs don't give that information. And
Mhm.
so in partnering with Zentis, we're able to now see our CARC codes, our RARC codes, whereas before we couldn't trend that. We were completely blind. So by partnering with a tool that gives us that information, we're now able to see what procedure is it? What is the remark code that's coming with that denial code? What doctor is giving us the most denials? So we
Mhm.
really have become very data heavy in making data-driven decisions that then we have that feedback loop to our teams at the practice level, being that, we're shared and remote, that helps us to optimize those upfront workflows, which by default give us the optimal result on the back end.
Yeah. No, that's
That's
great.
great.
Thank you. Nana, do you have anything to add?
Um, no, we can keep going.
Just a quick reminder to don't forget to stick around. We have a surprise for everyone at the end of our discussion here.
Yeah, awesome. Thanks. Thanks for that so far. So this is a good discussion. Let's take a look at how automation is changing denial management. And this kind of touches on some of the things that Kate said with Remit AI and what we've done as far as taking on those denial workflows that slow the teams down. I'm really surprised that in all our years of dentistry and the way technology is, that some PMS system hasn't already come up with a way to categorize those denials, because it's just such a huge piece, I think, and game changer, like you said, Kate, to now kind of be able to see what are those CARC and remark codes and where are things falling. So we've elevated denial management. We use AI to categorize the denials based on each payer's stated reason or those CARC and remark codes that come on the ERAs. And this approach provides clear visibility into denial trends. It helps teams to quickly identify patterns, address root causes more effectively. We've further refined these categories into specific classes as well, making it easy to identify and prioritize denials that require reprocessing. And this also provides clear visibility into the associated dollar values. So now you can also see, where does the team need to focus for the most impactful opportunity. We also have visibility, as Kate was saying, into what codes payers are denying and even providers. So, and why are these being denied? So this payer-specific denial report provides clear insight into which payers have the highest denial rates for your DSO or your practice. And it also enables tracking of those specific procedures being denied and the categories that those denials are falling into. And it also helps with unclean claims. So providing insight into the most denied procedure codes. Some of them you expect, but others, you plan for those to be paid on the first pass, like the SRPs and the crown and the buildup. So this gives you some visibility into why they're being denied. What are those categories that those are falling under? So you see if they're falling under needing resubmission or appealing, something was missing on that first submission. So it helps to clarify that. And then, of course, we have CaviAR, which is a claim tracing and AR management add-on to Remit AI. And this automates claim status tracing from submission to payment across all insurance payers, and it provides an intelligent workflow for reviewing outstanding claims and denials that require manual intervention. To do this, CaviAR pulls claims data from external sources and it matches those against the Remit AI claims. This gives billing teams full visibility into where every claim stands across the revenue cycle.
Thank you, Cheryl, for sharing that. I think that was important considering we're talking about denials and the best way to track and what we can offer. Now, Kate, can you talk about the roles automation plays and how you prevent and then resolve denials, especially related to how you utilize your MedAI?
Sure. Yeah, so, we're now working the exception instead of constantly calling and waiting on hold and getting the status. So we automatically have our denials data there. My AR team is working on those exceptions. And what they're seeing is not only pulling in the remit so that we can see all of the CARC, the remark, what was paid, specific line items that were denied, but they're taking that data that's already trended for us on our dashboard. And again, going back to the team, or we're even leveraging that in our payer negotiations. We're saying, listen, you denied X amount of dollars for us this year, or you downcoded us this many times. And we're using that not only to improve our processes, but also improve our negotiations in payer reimbursement.
That's
That's
awesome.
great.
Thank you. Now, Donna, what are you doing with your organization, and how are you guys utilizing Remit AI?
Yeah, similar to Kate, with having just unbelievable data transparency, and the ability to drill into a certain provider, a certain code, a certain payer. It really helped us target our conversations with our providers about their documentation, or getting close to them, like understanding why they get so many denials on this specific code, and really working with them on both providers and hygienists. And then, really evaluating what are the required documents. And we have a whole workflow around, attachments that need to happen for claims to hardwire that to make sure that those are being sent in the first place. So having the ability to really dig into our data and be very transparent of the who, what, where, why, and even at a payer level, like Kate was saying, to address that head on with the payers about certain denials that we repeatedly see, or by comparison to, like, hey, MetLife, why are you denying so much more than,
Yeah.
Right.
I'm glad you brought that up. We hear a lot from offices that we work with that specifically indicate the adjustment and workflows using automation by, really utilizing team members who are really strong in appeals or can dig into what happened and, help establish those workflows with their offices to reduce denial trends that they're seeing within different companies. Now, Donna, what changed when you stopped relying on manual workflows?
Well, a lot, because we're able to move a lot faster, and we post faster, we get paid faster. Everything just is so much more smooth. Even from upfront with at claim submission, our clean claim rate is in excess of 98 to 99%. Because we know where we were falling down, because we could see with the, electronic data what our issues were. Similarly for denials, just the transparency of the data, faster payment, faster posting. So it's allowed us to be much more efficient as an organization, and, much more profitable too. So, we move fast, and we get paid according to our contracts, which, by the way, then we can see and know that right away as well. So we can dig into that too if we have an underpayment. So it's just really been very impactful for us, because we can see all of our data so clearly.
Yeah, that's
Amazing.
awesome. Thank you. Kate, anything to add?
I really truly just mirror what Donna said. When you accelerate your workflows, that accelerates everything that comes after that, including your cash, and cash is king.
Yeah, that's true. Now this question's for the both of you ladies. What do you wish you had done sooner? And this is a tricky one.
I wish that we would have moved to a more, AI enabled and electronic process sooner than we did. We were relying on human beings to do manual work, and then didn't have a good way of, like, if there was a question later, like, where do we find that remit? Where is that EOB posted? It's in some shared file somewhere. And so having everything in one place that we can recall it at any time, has been very powerful for us as an organization. And even in our offices, like, they don't have to rely on the RCM team to well, let me resurrect that EOB for you.
Yeah.
That we have empowered the teams in the field to go pull that data if they need it. So I think, moving more quickly to an AI-enabled electronic platform has really enhanced our workflows, from everything from AR management, but also specifically denials. I know that's what we're talking about today, but I wish we would have done that sooner because it's just been so powerful for us as an organization.
Yeah, absolutely. Kate,
I
do you have
would
anything?
definitely echo that. I wish that we had done that, partnered with Zentis or, AI sooner, because for us in getting that denials data, we've now enhanced our workflows on the front end. We've increased our clean claim rate, and we've increased our efficiencies in not only our workflows, but our workforce. I have a FTE working 4 practices now because she's only working that exception. And if there is a time that she has to work that account from the ground up, we have everything that we need at our fingertips in our Zentis dashboard in CaviAR.
Awesome. Thank you for that, ladies. Now before we actually open up the floor to our live Q&A, we do have a couple of questions that we found interesting, and we wanted to add those to our list of conversations. One was how to get past the AI auto denials. I wanted to start with that one. That one I found very interesting. And I know Kate has something to add as well. I have some background and experience working with Delta Dental from years and years ago. And I think what we see a lot currently with our claims that we see coming in through RemediAI is offices are just resubmitting directly through their practice management system. They're not always utilizing that initial claim submission or referencing the initial claim. And what we have to remember is our payers are doing AI automated claim processing as well. So if the system recognizes same patient, same provider, same service date, same services, it will reject your claim as a duplicate. So we have to make sure that we're utilizing the resubmission, attach additional information, use your electronic tools through your clearinghouses, et cetera, to provide those additional needed documentations, or use specific, if you're needing to appeal the claim. I know a lot of these payers have specific claim addresses that you're needing to resubmit additional information to, and you're wanting to do those appropriately. Otherwise, the system will unfortunately kick the claim back out of the system as a duplicate, and it is not done by any human. It is auto-denied. And they're doing similar things to claims that are related to needing review. If they're seeing a high utilization or services that they consider services that they would like to review, those, if additional information is not attached within the claim, those claims are automatically coming back and requesting that information. So again, they're recognizing trends, they're watching for trends, they're looking at areas of zip code and providers who have higher utilization compared to providers in the area who maybe don't. The demographic is similar, so they're going to look at providers who have higher utilization on services.
I think, Anna, a lot of the payers, if you think about AI and bots, they're trained to do one thing, and that is, I go 2 steps forward and I take 2 steps right. And so you can start to identify those trends, and that's something that Zentis delivers on the dashboard is what you're seeing, how many denials for this particular thing. A great example of that is we had a doctor on his completely bony extractions was not writing removed bone in his note. And there was one payer that sent us on one remit. It had to been like 50 downgrades. And it was because it said that his note did not have removed bone in his completely bony extractions. And so, there, as much as the bot and the AI is trying to outsmart you, the thing about bots and AIs is they are consistent and they look and do the same thing over and over and over again. And so you start to see that trend. And once you get that again, it goes right back to our very first comment was collaborating with your practice team, with your clinical team, and making sure that you're making those shifts and changes in the documentation, in your templates, and educating your doctor on what they need for payment.
Yeah.
Thank
Absolutely.
you. Now our next question, how can we create a culture where denial prevention is everyone's responsibility, not just the billing teams? Donna, I think you wanted to touch on this one a little bit.
I love this question. This is like the best question ever. So I'm happy to answer that. Because it's all of our responsibility, right? In the dental office, we're one team, we all work together for the care of the patient. So it's not just a billing function, it's all of us, or like to say, we don't make the news, we report the news. But I think creating a culture where everyone has an eye toward that and like the goal of a clean claim, the goal of getting paid, that's why we're all here. And it starts at the beginning when the patient calls to make their appointment, getting that insurance information, getting the correct demographic information, and like even down to like how the patient spells their name, or do they use their middle initial? Because if their insurance has it spelled, if their name is Michael, but insurance has them as Mike, you're going to get a claim rejection. So really being very intentional from the first contact of the patient of obtaining that information and checking eligibility right away, and getting that coverage understood. And also knowing what are the waiting periods and the coverage tables and any exclusions or missing tooth clause, things like that, and then documenting it all in the PMS so that then the next person can see that as well. And then you create your treatment plan around that. So making sure everything there is correct. And then when you move back to the clinical care part, kind of like what we touched on a little earlier, training and talking to your hygienists and your providers about the denials that you're seeing, how they need to document. And I can't say this enough. It's not about like how you did the thing. It's why you did the thing.
Yeah.
And I think that's often, that was a struggle for us. We were great at saying, we used how many carps of Lido, but why did you do it? And so, really rounding out that documentation and helping people understand everyone has a part in this. It's not just, Donna in the back office submitting claims. It's all of us together, and we have to partner with one another, and everyone has a role in that. So I not just it happens on the back end, it's everyone. So I think that is very powerful. And when you engage people in that way, help them understand their piece in that process, and that their role is really important to the functioning of the organization or the office. There's no small job. So in getting people rallied around that and creating ownership, I think is really that has been impactful for us too. And it's not just somebody else's problem, it's all of our problem, and we solve it together. So thank you to whoever submitted that question. I love that.
Anybody else have anything to add to that?
I think Donna covered it really well.
You did. You definitely did. That open conversation piece with your team and is definitely key. Now, we have a little bit of time. Let's jump into some of these questions. I know we have some questions coming directly from our attendees. Danielle, do all of your operations team members have access to Remed AI?
Yes.
Yes. Mm-hmm.
And you can decide who has access to what as well. So we have different levels of access within the platform. So I know, we have some clients who they do have team members who they don't want them touching anything. They just want them to view. So we have that view only access where they can just, maybe download an EOB, but they can't actually perform any actions. And then you've got those people who have, a higher level where they can do the posting or do the reviewing of denials or, anything specific like that. And then you have the access to all of the reporting. So yeah, it helps to have those different levels.
Yeah, that's great, Cheryl. And our teams just to be clear, our teams in the field have view access. They can't change things, but they can view. And it's been very helpful for them that when that patient comes in to help me understand why I owe money, that they can pull up that EOB and walk through that with the patient. So we've put that power in the hands of our office teams. And I think that just creates a better patient experience and helps like kind of the field teams like learn and be fluent with that conversation of reading an EOB and why, and like it's patient facing. So really helping the patient understand, why things were paid the way they were.
And our office managers also play a very active role in going in and looking at their denials dashboard and their trending. I have one office manager, her goal is to make sure that there are no denials on her dashboard. So she actively is in there reviewing them, and she'll even take the time to resubmit for us the claim if it was something, or go ask about the charge capture or wherever the breakdown was. She actually takes initiative to do that. And then it has created some healthy competition among her peers to also achieve that. So
I want to also add there too something you said, Donna, about reading the EOBs, because especially when you've got new people on your team that maybe don't have that dental experience, that's one thing I do love about our platform is the standardized format that makes it easy. Some of these EOBs, my gosh, you can't even find the patient name. It's so jumbled and so difficult to read. And so if they've got that and they're trying to answer a patient's question, they can't even find the patient on the EOB. So to be able to just have it easily accessible for just that specific patient and easy to read, I think also makes it a little smoother for them.
Yeah, absolutely.
Absolutely. Let's see that we still have some questions here coming in, but if anybody would like to do an open discussion, do raise your hand and we're going to give you the floor. We do have some other questions that came in. One specifically related to timely filing. I know as Cheryl and I continue to work in the dashboard, we actually see this one quite a bit. Ladies, do either one of you want to take this one? Otherwise, I can add a little comments to that.
I can start and feel free to jump in. I mean, know your timely filing limits for each pair. They're not standard, they vary. What we did is create a spreadsheet. It's nothing fancy, that has the payer and what their timelines are for timely filing for initial claim submission, and then appeals timelines as well. Everybody in the organization can refer to it. But that, I know it sounds dumb and simple, but it helped. Also keeping like proof of when the claim was submitted through your clearinghouse or whatever manner that you have, to have proof, because I often think payers will just try to deny it for sake of denying and say, well, we never got the claim. And if you can prove it, at least you have a leg to stand on, an argument to be made. So, or you'll get the acknowledgement that we received it, and then they'll later say, I didn't. But if you have that documentation of when you sent it, that they received it and accepted it, at least you can, start to fight that denial. I don't know what else do you have?
No, I was going to add to this. I'm not sure if most of you know this, but regardless of in or out of network, you always have the ability to contact the payer and request a processing policy for their claims. And that should include per payer, their timely filing, their appeal filing, what their guidelines are for basic versus major services. And actually, they should indicate what they are per service. So if you've been contracted for quite some time, this is a good resource. You can always reach out to your provider relations department within each payer and request that documentation, so that you have a better understanding on timely filings, how to get those claims paid, etc.
Tammy has raised her hand.
Jump on
Hi.
in.
I just wanted, how are you guys doing today?
Doing well, thank you.
Thank you.
Awesome. I just wanted to kind of cover a little bit. We talked about our clean claim rate and first pass rate. So I just wanted to kind of walk through that because I hear those terms used a lot. And I just want to know, like, when you're using those terms, what is your definition? Because I talk about this a lot when I'm, speaking to other people, that what do you actually consider, your first pass rate or clean claim? Because you have a series of denial steps, right? You have in your PMS that can kick something out and tell you right away, hey, you're missing a date of birth. So are you considering that a clean claim? Are you considering when it goes the actual clearinghouse, it kicks it out, so you can get a denial there too. So that's two. And then you have pre-adjudication where they don't even adjudicate the claim, but it does hit the insurance, and post-adjudication. So that's 4 levels. And so I'm just curious of how you're actually using these terms.
So for me, I'm sorry, go ahead, Donna.
No, go ahead, Kate.
I was going to say, for us, my biller is doing a revenue integrity sweep prior to sending that claim out. So, the claim falls into her queue. She checks for charge accuracy, documentation to support it, attaches her x-ray, and sends it out the door. Now, I start tracking clean claim rate when it hits dental exchange, the clearinghouse. And if there is no manual intervention and it just goes straight out the door, that to me is a clean claim. So, I don't know if you realize there's a report in dental exchange that will tell you how many were submitted, how many had edits, et cetera. Yep. And that's where I start tracking.
Same here. That's how we measure and report that data. Same way Kate does. If it bombs out in dental exchange, it's a claim rejection. I hope that helps, Tammy.
I've just seen so many people use that term so differently. And it's like, wait, let's talk about how we're actually looking at this, right? Because there's so many different levels that claim can be rejected. And some people don't even count it unless it's kicked out by the insurance company themselves post adjudication. It's like, whoa, wait, there's so many steps before that.
Yeah.
Appreciate you walking through that.
Thanks, Tammy. There was a question in the chat too. I don't know if you saw that, Anna, from
Can our out-of-network providers request those processing? They should, yeah.
There's another
because their processing policies are based on the payer's processing policies. So that's in regards to what information is needed per service, like I mentioned earlier, or their claims deadlines in terms of submission. They could be different from in versus out-of-network, but those should be identified in those processing policies.
There was an earlier question about medical necessity. Do you have a sample template for medical necessity for dental codes?
Documentation of medical necessity? Well, it depends on the code and the procedure, and those are all embedded in our PMS, and it's customized to that procedure. And so there's so many components to a procedure. Off the top of my head, I can't think of a specific example or language, but it needs to be tailored to the actual procedure that's being done. There's no standard for everything. It's got to be unique to that code or procedure. They're beautiful. The ones we created. I tell you that.
Now, there's a question here that says, have you seen Aetna Dental requiring progress notes for SRPs? They're wanting to make sure that the patients came in for their treatment. I think this goes back to the part with utilization, and carriers are getting really picky when they see a higher level of utilization. It could be very specific to the policy itself. I think we sometimes forget that our patients are covered by their employers, and they really are the ones who are setting guidelines and provide coverage levels for their patients. And then the payers providing the actual coverage that they're looking for and providing to their employees. So oftentimes we will see a higher request of information, and if it's set by that patient's employer.
I think too, I would assume that you would be sending those progress notes in that SRP history when you send your perio maintenance. Typically, they may kick that out. If you're not providing that historical information when you do the perio maintenance, letting them know how that patient is doing, they will sometimes deny for that as well.
There's a question here. We're noticing some insurance companies are asking for narratives for perio maintenance or asking for full mouth series, um, like crowns or extractions. Does anyone know why? Um, the perio maintenance part, I think, has changed in the industry within the last couple years. And Donna, feel free to jump in here because I'm sure you're seeing a lot of this with denials and claims within your organization, or maybe not so much, but they're looking to just, confirm history. Our patients are oftentimes changing payers yearly. If the SRP was not covered by that individual payer, they're going to request to see if those services were done in the past to ensure that there's a need for service. And then with extractions, I think it's a trend to see uh, the full series of X-rays to confirm need for a surgical extraction. So we're just seeing that more and more.
And I think, did I see it pop up, a question about Pano and FMX?
Asking for a full mouth series for procedures like crowns or extractions.
Okay, it's not Pano.
That's been asked a couple times about the full mouth for crowns.
Oh, the bone grafts, extractions and bone grafts, and FMX or PAN has always been requested.
Yeah,
Well, I can say,
go ahead,
I was
Kate.
just going to say, in oral surgery, when they come in and they're going to have extractions, implants, anything that involves the graft, number one, the graft is almost never covered. So we charge the patient directly for that. Regarding the x-rays, they usually do a CBCT, a pano, or a PA. So any of the three, and some of them are pre-op and post-op and diagnostic. And so, it's really payer specific for us. And we've seen the teams will make actual cheat sheets for the payers. I mean, because it varies so much in what they want.
Mm-hmm.
And Kate, wouldn't you say that, the FMX looks at teeth and the Pano is jaw and sinus. And so
Yeah.
I think they want to see different things, especially before a full bony extraction.
Right. Yes. Agreed.
Yeah.
And also, we do a lot of cone beams. That's the CBCTs. And very rarely are we doing, the FMX and we do a lot of panos because a lot of even our implants, the zygomatic implants go up into the sinus cavity. So I think it's procedure specific, it's payer specific. It's really kind of hard to nail down, this is what you should do for every payer across the board. Kind of similar to the previous question of, what are you guys doing? Well, it's difficult for us to say this medical necessity is going to cover you across the board. It's kind of the same with, radiographs or any of the other things.
Yeah.
That's kind of where eligibility verification is important because you need to get that information from the payer before, when the patient comes in, before the patient comes in to make sure that what are those guidelines that we need? What do we need to make sure we're submitting with those specific codes and procedures? Yeah.
Yeah. Okay.
Tammy's asking, go ahead.
Let's say there's a question here that that again goes back to SRPs. We saw this one a lot. That actually indicates length of time spent in a chair. I think this maybe goes back. I think Shirley, you had some comments about, fraud, utilization, how much the industry, both health and dental, has changed.
Yeah, definitely. So I think they're starting to crack down. We kind of talked about earlier. There was an article in the ADA news recently about what they're planning to do with Medicare, Medicaid to kind of prevent fraud. And so I think they are cracking down more, paying more attention to all those little details and how important it is for us, again, to make sure that we're including everything that they request that first submission so that there aren't questions and we have documentation, as Donna said, as to the why that this procedure is being done so that we, that keeps us from, prevents us from any fraudulent, things coming against us, right? To make sure that we have the proper documentation on what's being done. I think as far as how long a patient is in the chair, again, I guess that is, I'm not familiar with that or haven't seen that. I don't know, Donna, if you have on
Yes.
SRP.
Yeah, not all payers, some have, and I think if I can channel my hygiene director, that an SRP takes longer than pro fee.
Right.
And so the payer wants to confirm, in addition to the documentation and the x-rays and the probing depths, that the patient really received this and really needed it. So I think, Cheryl, to your point about fraud, because reimbursement is greater for an SRP than pro fee. So I think they want that proof of like time start, time stop to prove that the SRP was actually done. Because if you said I did an SRP in 5 minutes,
yeah,
probably not.
Wow. Did they just have one tooth?
Right.
Well, there's a question here that I think Kate can help with. Are you billing medical at all for OS?
We are. So things that are specifically medical, like biopsies and pathology, we'll bill that with our office visit to medical. But if it is strictly dental in nature, then obviously it's just going to the dental. And that's really important about accelerating our AR work and our denials too, right? Because in OS, we're having both medical and dental claims. Medical takes longer to adjudicate than a dental claim does. Our payer cycle time is longer, which, having the information right at our fingertips to accelerate at least the dental portion can really be helpful in the oral surgery environment.
Awesome, thank you. Another Aetna. Aetna is a stinker. For length of appointment for SRPs. Thank you for that, Tara. I think we're seeing that trend here. Now, does anyone else on the call have any additional questions? We might take one or more still from our attendees that came through on the original registration. Does anybody want to raise their hand and ask a question?
I have a comment.
Yeah, please.
About like Aetna and SRPs. They don't want in the x-rays that are sent any overlapped images of connection points of teeth, or if not showing bone loss. So if it's not like a diagnostic x-ray, they will deny that SRP.
I have seen that too. Anyone? Oh, yeah.
Oh, there's one in the chat.
Do you want to take that one, Cheryl?
Well, I'll read it. Yeah. How do you navigate denials due to information that has been submitted, but the insurance company says they can't find it repeatedly? It is in the unusual remarks and clinical notes.
We'll take ours and direct bill it directly to their website. And if that fails, then we mail in our claim. I mean, it's crazy that in today's world, we're still sending things via snail mail. But we get that a lot too, that we didn't see your attachment. Well, you did. We have the NEA number. It's right here in the comments section. Nope, sorry, still can't see it, even though you put it in neon lights for us. So then we'll go directly to the payer portal, direct bill it with the attachments. And to be honest, sometimes that fails too. Payers are very, very finicky. And then we resort back to sending the old mail claim.
Yep, we do the same. I think it's a game, unfortunately, and they're trying to wear you out. So yeah, we will submit in all the ways, multiple times. It's unfortunate, but it happens.
Is there another one? I think it was.
Yeah. Is there any getting around frequency denials?
That's a tough one. I have seen a lot of payers do, 2 in a 12-month versus 2 per year, or, in a calendar year. So I think really understanding your patient's benefits, because there's a difference between 2 in 1 calendar year versus 2 within a 12-month period. Calling and asking for an exception has worked for me in the past. Most insurance carriers will do an exception of once per patient per lifetime of adjusting x-rays. I've done that working for Delta. That was one of our processing policies. Look at your patient's history. You can adjust one time. So asking the question does not hurt. Some actually allows some leniency if done within 1 month or 2 months. But again, it's a phone call. You have to get to a customer service representative for them to make that exception for you. I've even seen things being overwritten if done for surgical necessity, especially related to panoramic x-rays that are needed to do surgery. So definitely ask the question. Sometimes making that phone call, especially if you're really, really close to frequency deadlines.
Tammy, you kept raising your hand. Did you have a question? Additional question?
Can you hear me?
Yes.
Okay. Just one thing that I wanted to add, well, to one of the questions I wanted to add, when they're putting it in the remarks for unusual services, with all the auto adjudication right now, I've been told that if they're not expecting a remark, that they don't read it when it's the AI doing the claim. So it's almost like a moot point to be able to put a remark because you're trying to say something extra, or you're saying, hey, refer to this claim because you denied this before. They're skipping it. So those are almost like you have to call if it's not something they're expecting to see a remark for, that it's just being auto adjudicated and missed. The other thing that I just wanted to add with denials, we use our reps a lot. Like instead of us doing the work, we make them do the work. So we will give them a list and say, look, you've done this repeatedly. Here's your pattern. Now you need to go fix it. So just another tidbit of something that we do. Appreciate you guys. Thank you.
Thank you. Now, just as a reminder, we are going to send the recording, and we will follow up as well with the questions that were submitted by our callers and then the answers, especially in regards to the questions that we did not cover during the seminar. Cheryl, did you want to do the closing? I know we have just a few minutes.
Yes, absolutely. So first of all, just wanted to thank you all for attending today and participating in the discussion. We hope it's proved helpful for you. We especially want to thank Donna and Kate for joining us today and offering their expertise. Greatly appreciated, ladies. Now, who's ready for the surprise gift? All right, drum roll. I'm going to share here my screen. So we're giving a 30% off disc ticket to our Dental RCM Bootcamp 6.0 to everyone here. You're all getting the 30% off ticket. So take a picture of that screen so you have the code to be able to get your 30% off ticket. In case you don't know, the boot camp is hosted by Zendesk. It's a premier event for high growth DSOs and dental groups. And it's going to be in Nashville, Tennessee this year. And it's going to provide you opportunity to join the industry's most influential leaders in dental revenue cycle management, finance, and operations for 2 days of intensive learning and collaboration, and of course, fun.
A lot of fun. We have fun.
Yes. So make sure you have the information on the screen there for that. And then finally, if you would like to book a demo with Zendesk, you can scan this QR code on the screen as well, and you can get that demo booked. So thank you everyone for being here. Appreciate it.
Yes, we thank you. And we do have 2 minutes, so if anybody has a quick question, we can try to cover one more.
Danielle Cuthbertson, hey.
Yeah.
We have a lot of Medicaid patients, and Medicaid has 2-year frequency on fillings. I used to appeal almost everyone that denies for frequency. Oh my God, it's moving. But now that the MCO are more involved, I don't know if that's a way to get them paid. Anybody have any comments on that? Don't have as much experience with Medicaid.
We deal with Illinois and Indiana Medicaid.
Mhm.
I have not experienced that with frequency for fillings and a change with the MCOs. But maybe, Anna, like what you had said earlier about calling and asking for an exception would be the
Yeah.
only thought that I have, calling that MCO to say, can you, make
Yeah,
an
one
exception for
thing
this filling?
that yeah, one thing that has worked for me, especially when there's a provider guarantee involved, is to consider, is it recurrent decay and patients at fault, or did the filling chip when we're redoing the work? And if it is a frequency, if there is indeed recurrent decay, but the composite was an MO and now it's a DO, oftentimes they will consider that additional service. We just have to appeal that. Or providing information that there's just a lack of compliance on the patient's end. But unfortunately, it has to be appealed, and it's a lot of work on the office level to provide that information where there wasn't time to contact the patient wasn't compliant, et cetera, so that it doesn't hit back on the office. All right. All right. I think we're at time. We know
Yeah.
everyone's busy, and wants to get back to their day. We really appreciate everyone coming on.
Yes, thank you so much. I hope everyone has a great rest of their day, and we'll send you the recording of today's roundtable as well as answers to questions.
And